Hello, and welcome back to another chapter of Pediatric Primary Care. Today we're talking about Chapter 8, the Developmental Principles and Theories. So, this chapter introduces basic developmental principles and theories, with an emphasis on the vital intersection between development and health. The concept of developmental surveillance is introduced, highlighted recent changes, followed by a brief overview of the parent-family development and theories. This introductory chapter is followed by 5 chapters, each of which highlighting age-specific development surveillance, health supervision issues, screening tools, red flags, and family resources. The 5 age groups include the neonate, so 0 to 1 month, the infant, 1 to 12 months, early childhood, 1 to 5 years, middle childhood, 6 to 10 years, and finally the adolescent, 11 to 21 years of age. Collectively, these 6 chapters serve as a foundational knowledge for primary care providers tasked with understanding the dynamic nature of development, as well as integrating and applying it into pediatric primary care in the midst of an ever-changing environment and society. Understanding development concepts and principles, the evolving context in which newborns, infants, children, and adolescents live and learn, and how they all interact is foundational knowledge for pediatric primary care physicians. A number of theories have contributed to our understanding of child development over the past century, but have come under criticism over time, especially in the term of contemporary understanding of gender and contemporary lenses of diversity, equity, and inclusion. Alternative theories, as well as theories from other disciplines, are now used to examine the impact of modern societal contexts, advances in science and technology, and the expanding use of media. Underlying all of these theories are basic developmental principles, each of which is introduced and briefly discussed. Development is a dynamic and lifelong process. Development reflects gradual changes and expanding capabilities, each of which allows for simple skills and behaviors to be mastered and integrated into more complex skills and behaviors. Milestone achievements at early levels set the stage for achievement in later levels. Simple behaviors, such as self-feeding, are often taken for granted, yet each milestone is the result of the acquisition of numerous small changes and skills. While pediatric primary care physicians closely monitor the developmental changes during the pediatric lifespan, we all continue to develop throughout our lives, with each advancing level marked by subtle changes and advancing integration. There are different aspects of development, and each is dynamically related to the other. Development can be examined as a whole and/or by its individual aspects or domains. Biophysical development focuses on organ development, including the brain, sensory abilities, and advancing motor skills. Cognitive development focuses on information processing, including language acquisition, problem solving, and other learning abilities and skills, with an emphasis on the sociocultural environment in which the child learns. Psychosocial, psychosocial development focuses on personality, including temperament, emotional regulation, attachment, and relationship with others. While each aspect can be studied separately, they do not present independently and most often need to work together. An example of this is the ability of a child to walk involves both brain organization and muscle strength. Development is systematic, organized, and successive. Developmental progression is predictable, which makes it easier to assess for deviations from the typical. Developmental changes occur in an orderly and predictable manner, with the specific changes occurring together to support specific skills and behaviors. Each successive change relies on successful attainment of earlier changes, resulting in skills and behaviors that are increasingly regulated, organized, and differentiated. Much like growth patterns, development follows a cephalocaudal and proximodistal progression. A child needs head control before they can sit. They need to be able to sit as well as grasp and release, to be able to bring two hands together to examine and transfer, or learn about different objects. The pace of development, however, is not universal. Each child progresses at their own pace, which means development occurs on a spectrum. Accordingly, there are ranges for attaining biophysical, cognitive, and psychosocial milestones. For example, one child will walk early but be slower to speak, while another will speak early but be slower to walk. Some children progress smoothly, while others do so in fits and starts. There can be critical or sensitive periods for development. The early pediatric environment is formative, and its effects on development are important. Critical periods are points in time when it is thought that something must occur, so a biological or environmental event, to ensure normal development. These periods reflect times when new skills or abilities develop, but only when specific exposures or experiences. However, if specific exposures and experiences are not available during that time, it becomes much harder or even impossible to develop or acquire the skill or ability after the window of opportunity closes. While critical periods are often associated with fetal development, there are also infant and childhood critical periods surrounding vision, hearing, language, and psychosocial development. In contrast, sensitive periods are points in which time when a development is most likely but does not have to occur. These times are often referred to as windows of opportunity, and are times when the brain is most likely to strengthen important connections and eliminate unneeded ones. However, new synapses still form outside of this optimal period, despite it being more difficult. Both nature and nurture shape development. The term nature refers to our biological processes, including our genome, which have the potential to influence every aspect of development. In contrast, nurture refers to our immediate and expanding environment, from the womb to home, to school to community, and the people in those environments. Past conversations about nature versus nurture shifted to understanding how nature and nurture work together to shape development. While our individual genomes include our unique DNA, which is fixed, they also include proteins that regulate gene expression, turning gene activity on or off, and these proteins can change in response to our experience and exposure. This discovery led to the field of epigenetics, exploring how gene expression is mediated and moderated by our internal and external environment. Developmental theories. Developmental theories provide different lenses for understanding emerging behaviors, personality, and abilities. They attempt to account for how children's development is affected by who and what are around them. Being familiar with a number of different theories helps pediatric PCPs to understand the various developmental aspects to consider as they care for newborns, infants, children, and adolescents. In this section, a subset of theories is introduced, beginning with well-known psychoanalytic, cognitive, and learning theorists, while also including less familiar information processing, ethologic, and system theorists. Individually and collectively, these theories, along with others, help to provide insight into the increasingly complex intersection between development and health. Each theory has valuable insights to offer. So here is a wonderful spot to hit pause so you can see the different cross-sections of developmental theorists. There is the psychodynamic, cognitive, learning, ethological, the system, and finally ethics. There's more detail to it, so please hit pause and review them accordingly. Psychodynamic theorists. Psychodynamic theorists focus on personality and emotion. They view development through the lens of conflict resolution, with different ages facing unique conflicts that need to be resolved for success or adaptive development. They also view development as discontinuous or staged, with each conflict or stage viewed as qualitative different from the others. Psychosexual Sigmund Freud, for instance. Freud proposed that an individual's personality is made up of three conflicting forces, and healthy development is the ability to balance them as children pass through a series of stages, during which maturing biological instincts interact with different erogenous or pleasure zones. The ID or id, which is present from birth, operates on the pleasure principle, constantly seeking to satisfy basic impulses, urges as quickly as possible. During the first year of life, the infant in Freud's first or oral stage, varying pleasure is centered around the mouth, including sucking, chewing, and biting. Later in the first year, the ego begins to emerge. The ego operates in reality, seeking to find a way to satisfy the id's need for immediate gratification in socially acceptable ways. During the second year of life, biological maturation gives rise to the anal stage, shifting the pleasure zone to the bowel urine elimination. The stage lasts until the child is approximately 3 years of age, at which time the focus of pleasure migrates to the genitalia. This is the phallic stage, which lasts throughout early childhood until the child enters school age, so between 5 and 6. At the beginning of this stage, children theoretically desire the opposite sex parent and compete with the same sex parent for the other parent's attention. This ongoing conflict gives rise to the superego, or conscience, which enables children to control their behavior based on what they internalize from their parent or caregivers as right or wrong, or acceptable versus unacceptable behavior. Resolution occurs when the child aligns with rather than competes with the same-sex parent. This is also referred to as resolving the Oedipus complex for males and less-known Electra complex for females. The fourth or latent stage occurs during the school-age years, during which sexual impulses are suppressed and pleasure is redirected to intellectual and social activities. These activities further develop the superego. The final or genital stage occurs during puberty. During this stage, sexual impulses reemerge and the adolescent must learn to satisfy their sexual needs in socially appropriate manners. Freud's psychosocial theory has fewer and fewer followers over time, as there is much less emphasis on internal urges in later psychoanalytic theories. However, both Freud and his daughter Anna are credited with introducing the idea that early childhood experiences are important. Neo-Freudian, as well as other contemporary theorists, clinicians, and researchers, continue to learn about the effects of early experiences, both positive and negative, on children's immediate and long-term behaviors, beliefs, and health. Psychosocial Erik Erikson. Erikson was influenced by Freud, but widened the scope beyond biological urge to include social factors, such as cultural influences, and the larger social world, contemporary issues. His theory is also different in that its 8 stages extend across the lifespan, while Freud's ended with adolescence. With each of Erikson's age-related stages focuses on a developmental task or conflict set up by biological maturation and expanding social demands. Erikson believed that if the developmental tasks and conflicts were not resolved, the individual would continue to struggle, with the unresolved conflicts surfacing during and at times interfering with future stages. 6 of these stages occur during the pediatric lifespan, each of which are presented in Table 8.2. Of note are the parallels with Freud, as Erikson's first stage parallels Freud's oral stage. The second stage parallels Freud's anal stage, and the third stage parallels Freud's idea of the superego. The other psychoanalytic theorists. There are many other psychoanalytic and neo-Freudian theorists. In this section, we highlight a few whose theories continue to impact pediatric practice, including Anna Freud. Anna Freud expanded on her father's work, focusing exclusively on children and calling attention to the important role development processes play as a child grows. This is credited with introducing the idea of defense mechanisms and the idea that personality depends on the overall process of these defense mechanisms, which include repression, regression, denial, projection, reaction formulation throughout their development. Melanie Klein. Melanie Klein is recognized as the first object relations theorist and the first to use play analysis. She believed that by watching children at play, an analyst can gain a deep understanding of the psychodynamic processes taking place in the child's mind. Harry Sullivan. Harry Sullivan introduced the idea of interpersonal interaction, or what goes on between people, are more important in personality development than the intrapersonal interactions, or what goes on inside people. He believed our developing sense of self is enhanced and or inhibited by and through the reflected appraisal of others. As a result, a child's early and evolving exposures are seen as crucial. Margaret Mahler. Margaret Mahler was a pediatrician turned psychoanalyst whose understanding of child development centered around the concept of separation individuation. She emphasized the importance of mothers and the need for infants to separate from their mothers on their journey to develop their own individuality. Mahler created and taught the tripartite treatment model, a therapeutic approach to involving both the child and mother. Donald Winnicott. Donald Winnicott was a pediatrician turned psychoanalyst who introduced the idea that for children to develop a healthy personality and realize their true self, they needed to move from subjective omnipotence to objective reality with the aid of a good enough mother. Not a perfect one. He is also credited with understanding that transitional experiences children must go through may be facilitated by transitional objects, such as a blanket or a stuffed animal. Winnicott introduced the squiggle game, a therapeutic technique that allows children to draw pictures to represent their thoughts and feelings. So, on this table here at table 8.2, it's a good spot to hit pause so you can review the Erikson's first 6 developmental stages, whether it is basic trust versus mistrust, autonomy versus doubt, initiation versus guilt, industry versus inferiority, identity versus role confusion, and finally intimacy versus isolation. Which brings us now to our cognitive theories. Cognitive theories focus on the way children think and how thinking evolves over time to influence development. The three most influential cognitive theories are Piaget's stage theory, Vygotsky's sociocultural theory, and more recently, information processing theories and theory of the mind. Both Piaget and Vygotsky are considered constructivists in that they focus on the way children construct knowledge. Information processing theories are broad and focus on how children attend to and store information, while theory of the mind, or TOM, is specific to processing information about others. They are similar to that they all recognize children as active participants in their own development, while Piaget's state approach supports discontinuous development and information processing, and theory of mind supports the notion of continuous development. Vygotsky acknowledges both continuous and discontinuous development, but is primarily continuous. Constructivists, Jean Piaget, stage theory of cognitive development. Piaget's theory focuses on children's progressive creation of menstrual structure, or schema, which are the way children make sense of their experiences. Adaptation refers to the process of building schemas, which occur by assimilation and accommodation. Children can assimilate new experiences into existing schemas, or they can adjust existing schemas or create new ones when existing schemas cannot accommodate their new experiences. During times when children are not being exposed to new information, assimilation dominates. Piaget referred to this stage as cognitive equilibrium. During periods of cognitive stimulation and change, children experience cognitive disequilibrium and rely more on accommodation. Children can also build schemas through organization, which is when children link and organize existing schemas into new interconnected systems. Piaget proposed that the organization of schemas proceeded through four universal stages that occur in a fixed order. Each of these stages represents a period when schemas are qualitatively similar. Piaget's stage theory of cognitive development is widely known and referenced, and it was influential to the work of his contemporaries in the fields of moral reasoning and spiritual development. However, Piaget has also been criticized for his tendency to underestimate the capabilities of the child. Lev Vygotsky's sociocultural theory. Vygotsky was a contemporary of Piaget, but took a totally different approach. While Piaget believed development preceded learning, Vygotsky proposed the opposite, that learning preceded development. It is a subtle but important distinction. Vygotsky stressed social interaction, viewing development in terms of what children could achieve with help of others, rather than what they could achieve on their own. He also focused on an endpoint rather than stages, and the social processes that impact getting there. Core to Vygotsky's theory is the zone of proximal development, which is the space between children's actual developmental level and what they learn on their own through independent problem solving, versus the next or higher developmental level, or what they can do with guidance from adults and more capable peers. In the CPD, others provide scaffolding or guidance until children achieve standalone competence in their task or skill being mastered. Vygotsky is known for his strength-based lens, pointing to what children can do, which is often contrasted with Piaget, who used a deficit-based lens, pointing to what children are not yet able to do at each stage. Which brings us back up here to the Piaget's stages of cognitive development. Again, here's a great spot to hit pause so that you can see all the different age groups, as well as its coordinated stage. So whether it's sensory-motor, pre-operational, concrete operational, or formal operational. And as always, if I'm ever going to quickly hit pause. Information processing theories. Information processing theories present another way of examining and understanding how children develop cognitively. They first emerged in the late 1960s to early 1970s and had an enormous impact on the study of cognition. At their core, these theories conceptualize the human brain using the metaphor of a computer processing, encoding, storing, and decoding data. Unlike Piaget, there are no stages, and unlike Vygotsky, there is little focus on social interaction. Instead, these theories concentrate on cognitive processes, beginning with what information children attend to, how that information is encoded, and how and if it moves from their working to their long-term memory, and how it is retrieved and returned to the working memory for relearning as new information is being processed. Infants and toddlers learn primarily through sensory input from their surroundings. However, during childhood and adolescence, there is increased attention and ability to focus the attention, faster processing, increased working memory, and more efficient information processing. Cognition, the theory of mind, or TOM, refers to the children's developing ability to understand the mental states of others. At first, it is recognized humans as mental beings who have minds full of mental processes, intentions, beliefs, perceptions, emotions, all of which influence behavior and action. Around the age of 3, children begin to learn that others are also mindful, and that their thoughts and beliefs may be different than theirs and, even when similar, may lead to different behaviors and actions. In some ways, theory of mind is better understood as a social cognitive skill than as a theory. It is referred to as a theory because one person's beliefs about what might be going on in another person's head is just that, a theory. The children's theory of mind abilities progress sequentially, with most children able to pass theory of mind tasks by age 4 to 5. However, theory of mind is relatively unstable, as children may understand mental states in some situations but struggle in others. Theory of mind abilities continue to improve and develop through late adolescence and into adulthood. Of note is that children's theory of mind's abilities align with their social competence, as those children who are more adept at understanding what other people are thinking tend to have stronger social abilities. So here's a good spot to review box 8.1, the theory of mind progressive sequential tasks. Learning theories. Learning theories focus on how experience affects learning and the importance of learned behavior. Accordingly, the emphasis is on children's exposure and experiences, so nurture, and development is seen as continuous. This group of theories is typically divided into two categories: behaviorists, who emphasize observable behavior, and social learning theorists, who emphasize observable learning. Behaviorists would include John Watson, who was an American psychologist who built on the work of Russian psychologist Ivan Pavlov, who first documented the concept of classical conditioning. Classical conditioning is a type of learning in which a particular stimulus becomes associated with a particular response. He felt that learning occurred through ongoing stimulus-response associations, and that children's environments were the main factor influencing how children developed, based on the stimuli they received. While children developed, I'm sorry, while highlighting the importance of children's environment is one of their strengths of Watson's theory, the main critique is that Watson saw children as passive. B. F. Skinner, however, distinguished himself from Watson in a number of ways. First, he viewed children as an active participant, or operator, interacting with and having an impact on their environment. He was particularly focused on how the consequences of actions influenced subsequent behavior, introducing the concept of an operant conditioning. Operant conditioning proposes that actions followed by reinforcement will be strengthened and more likely to occur again in the future. Positive reinforcements are favorable outcomes or events presented after a positive behavior, while negative reinforcers involve the removal of unfavorable or unpleasant outcomes after a positive behavior. Both are directed at having the positive behavior repeat itself in the future. Reinforcers are distinct from punishment. Punishment involves administering an adverse outcome or event after an undesirable behavior, with the aim of stopping that undesirable behavior. Table 8.4 will provide a visual schematic difference differentiating reinforcement from punishment. Skinner's concepts form the basis of therapy using behavioral modification. Social learning. Albert Bandura said that learning was inherently social and that children played an active role in their own development. He emphasized observation and imitation rather than reinforcement as key mechanism in child development. He stressed that children can and do learn in the absence of reinforcement and punishments through observational learning or modeling by watching and or imitating others, both real and symbolic, whether it's adults, parents, caregivers, or books, characters, TV or movie actors. He emphasized the role of cognitive processes in observational learning, attention, encoding, storing, and retrieving information, which parallels contemporary information processing theories. Later in his career, he introduced the theory of self-efficacy, which is the belief that individuals manage or are successful in a given situation. He perceived self-efficacy as also influenced and learned by observing how others succeed. So here we'll take a quick peek at the operant conditioning, the reinforcement versus punishment. Again, a good spot to hit pause so you can kind of review. Ethologic theories. Ethology focuses on the evolutionary behaviors by exploring their ongoing adaptive or survival value. Konrad Lorenz, a zoologist, is often referred to as its founder, while John Bowlby, a psychologist, is known as one of its many influential applicants. So, speaking on Konrad Lorenz, he introduced the concept of imprinting, an instinctual behavior in birds that keep their young near, protected, and fed. It occurs during what Lawrence calls the critical period of development, which are points in time when it is thought that something must occur to ensure normal development. John Bowlby built on Lawrence's work, shifting from animal to infant attachment. He also introduced sensitive periods of development, which are points in time when the development is most likely, but does not have to occur at that time. Bowlby argued that infants need to develop a primary attachment bond with a specific figure during infancy and early childhood. He also argued that infants needed their mothers in particular, and the absence of a specific or consistent mother figure during infancy would have long-term detrimental effects on the child's mental health. Bowlby's work has been amended, noting bonding with at least one parent figure is sufficient for optimal development. System theories. System theories introduce an interactionist view of child development, including the idea of intersectionality. Interest and intersectionality is also used to understand how aspects of the individual's different identities, race, class, and gender, may interact and or combine to create discrimination, social inequality, and injustice, as well as privilege. While there are a number of system theorists, Bronfenbrenner ecological theory is highlighted, as it focuses specifically on children and provides an ideal example of the complexity involved with a system lens and integration of intersectionality. Yuri Bronfenbrenner saw development as occurring in an environment of nested, interacting layers of systems, with the child at the center. He viewed children as active agents, bringing their own complex interacting constellations of characteristics. His interactionist view of child development draws attention to how different layers of systems affect how a child develops with a result of their interactions, as well as how a change in one system can affect the others. The nested layers include the microsystem, which is the child's immediate environment, including who the child directly interacts with, family, peers, daycare, school, extended family, and a setting in which they are nurtured and learn. The mesosystem, which are the relationships connections among microsystems such as homeschool, the exosystem, the social context, setting that the child is not a part of, but that they affect the children's development, so the parent's workplace, mass media, school board, community health services. And finally, the macrosystem, the broader socio-cultural and political context in which the child and all the other systems are embedded, which would include laws, attitudes, values, culture, social class. And finally, the chronosystem, which represents how time affects the child and its environment. So, taking a quick peek here at figure 8.1, it's again a good spot to hit pause so you can have a visual aspect of the Bronfenbrenner ecologic system theory. Developmental surveillance and milestones. Developmental surveillance or monitoring is an integral part of every pediatric visit, as it provides insight into the children's ongoing developmental progression, parental concerns, and/or which children might be at risk for developmental delays. A developmental delay or quantitative departure from typical development progression in that development is proceeding but slowed. Developmental delays that persist beyond 6 years of age are typically considered a developmental disability, as these delays are more likely to persist in some capacity. Other quantitative departures include asynchrony, which occurs when different aspects of development proceed, but are out of step, such as regression, when there is a loss of earlier progress in skills, and precocity, when development is accelerated. A qualitative departure or deviation is said to occur when a behavior appears that would not be expected. Developmental surveillance typically involves the use of developmental milestone lists and charts that are reviewed collaboratively by primary care physicians and parents. In contrast, developmental screening, while also integrated into health supervision visits, typically involve the use of specific tools completed at specific ages. Screening is also done when ongoing developmental surveillance reveals a concern. Diagnostic evaluations are done for children with concerns or risks identified through surveillance and screening. In 2019, the American Academy of Pediatrics revised the Learn the Signs Act early checklists used for pediatric developmental surveillance according to evidence-based criteria. The resulting universal checklists are updated and easy for families of different social, cultural, and ethnic backgrounds to understand and use. Two major changes were to one, add new checklists for the 15 and 30-month visit, and two, shift the milestone achievement time to the point at which 75% versus 50% of children should have achieved that milestone. The final product highlights 159 milestones and 12 checklists. These checklists include information that should be included when providing anticipatory guidance. So, touching on anticipatory guidance. The goal of anticipatory guidance is to help parents and caregivers plan for and cope with upcoming or anticipated developmental changes and challenges. It is age-specific, highlighting information about developmental changes, as well as related practices that promote health and prevent injury and disease. Anticipatory guidance is typically provided during well-child visits to parents, beginning with the first infant visit and extending across the pediatric lifespan. As children age, should be increasingly included in the conversation as they too can be prepared for what is coming next. Anticipatory guidance is an ongoing conversation that includes information that reinforces positive health behaviors, minimizes or eliminates health risk, and facilitates optimal family functioning. Being open to, listening to, and engaging caregivers in these conversations help build their confidence, create a trusting relationship, and establishes comfort for bringing forth more difficult concerns when necessary. The various components of anticipatory guidance may include assessing caregivers, providing age-specific information about, continuous evaluation and reinforcement of positive caregiver styles, as well as strategies to foster healthy caregivers' role development, including caregivers. Talking with caregivers about developmental delays. Having an established relationship that includes ongoing discussion about development makes talking with caregivers about their child development easier if developmental delays or issues begin to appear. Caregivers are often the first to suspect or even notice differences. Primary care physicians need to listen and be sensitive to their concerns as they seek reassurance or confirmation. However, some may choose to wait until the primary care physician notices or initiates the conversation. Either way, when a developmental concern arises, a strength-based approach is advised, as focusing on strengths first provides parents with a framework for understanding their child's unique strengths along with the particular developmental challenge. Above all, it is important to be honest, positive, and realistic. Caregivers want to know what they can do and specifically how they can assist their child. They also need support and time to cope with their own feelings. Different families have different expectations for their children, so a child with mild delay may be more devastating to one family than a child with severe developmental delay may be to another. The caregiver's role, understanding developmental concepts and principles, as well as the evolving context in which our pediatric patients live and learn, is not only foundational knowledge for pediatric practice, but is also foundational knowledge for parents and caregivers in terms of how best to approach child rearing. In fact, knowledge of caregiving and child development is a protective factor in the prevention of child maltreatment. So we'll discuss that more in chapters 9 through 13. Understanding that children benefit from close and dependable relationships that provide love, nurturance, and security also point to why caregivers are key aspects of pediatric practice. Taking the time to learn about their backgrounds, experiences, and current environmental influences is critical to understanding what individuals bring to their caregiver's journey. Collectively, this information can help primary care physicians tailor their information and support that they provide to caregivers, individualizing developmental knowledge and skills for each family. Behavioral economics. Behavioral economics combines the field of psychology with economic theory to leverage predictable patterns in decision making to explore how to move individuals in the direction of better decision making and overcome barriers to behavioral change. This emerging field offers both insight and tools to the primary care physician to develop novel approaches to supporting parental decision making while improving the child's health. Primary care physicians' efforts to impact caregiver behavioral changes are influenced by caregivers' cultural influences and beliefs, economic status, and social view, each of which presents challenges to behavioral change. The shift to behavioral economics draws attention to ways in which individual families, community, and cultural contexts affect caregiver decision making. Behavioral economic strategies or nudge focus on the influencing behavior predictably without restricting choice using message framing, defaults, and enhance active choice and leveraging social forces, implementation prompts, and in-group messengers as effective strategies. For example, when discussing actions targeting prevention, it is important to emphasize the potential benefit of the action When discussing screening interventions, the emphasis should be on the potential harms of inaction. Each of these strategies is grounded in an understanding of cognitive bias and behavioral constructs, or levers, that impact on leverage decision making. Some examples of these constructs include present bias, availability, heuristic, optimism bias, information avoidance, hot-cold empathy gaps, and choice overload, amongst others. By better understanding behavioral levers, primary care physicians can increase the salience of their messaging by designing tailored interventions specific to the most prominent biases within relevant subgroups. One of the best examples of using behavioral economics is the focused effort to enhance safe firearm storage. Family. There is a continuing shift away from focusing solely on caregivers to looking at families as a complex social system. The family system approach acknowledges individuals, the mother-child, father-child, and sibling-to-sibling. The collective interactions, such as family dynamics and functioning, as well as the direct and indirect influences from outside the family. Direct influences include the family's culture, customs, values, and traditions, immediate neighborhood and larger community. Indirect influences include the impact of local and government policies on food insecurity, availability of and access to green spaces, and access to high-speed internet. Chapter 5 provided information about assessing family composition and structure, family development, or life cycle stage, and family functioning. Some additional resources. Child Development by Crowley K. Child Development, a practical introduction, as well as the Hauser Cram, The Development of Children and Adolescents. There are again some professional parent resources, the American Academy of Pediatrics, the Brazelton Touchpoint Center, Bright Futures, Center of the Developing Child at Harvard University, Hawaii Early Learning Program, Parents as Teachers, and 023. We're also going to touch here on Box 8.2, Behavioral Economic Examples of Cognitive Biases or Levers, Non-Random Errors in Thinking in Terms of Formal Logic. Again, there is the action bias, the present bias, availability heuristic, optimism bias, in-group or out-of-group bias, that hot-cold empathy gap, and choice overload. Again, it's an excellent spot to hit pause before we finish off our chapter here. We'll take a look at some of these references in case you need them. Other than that, this is the completion of our chapter here today. I thank you for listening as always, and I'll see you at the next chapter. Take care and have a good day.